Bom dia a todos. I'm Dan Kuritzkes, and today I'm going to talk to you about resistance considerations when choosing an integrase strand transfer inhibitor. These are my disclosures. There are now 4 approved integrase inhibitors in the United States and in most of the rest of the world, including Raltegravir, Elvitegravir, dolutegravir, and Bictegravir. And we anticipate in the next weeks or months that a 5th integrase inhibitor, cabotegravir, will be approved as well. One challenge in the use of these drugs is that each of these drugs can select for drug resistance mutations, and as you can see in this slide, these mutations are shared in common by all of the integrase inhibitors. Although the relative importance of any particular mutation differs from drug to drug, if enough mutations are accumulated, there can be broad cross-resistance within the class. This cross-resistance is illustrated here in these data from Smith et al. Published 2 years ago in Retrovirology. And you can see that resistance to Raltegravir and Elvitegravir, so-called first-generation integrase inhibitors, is mediated even by single mutations, such as changes at positions 143, 155, or the combination of 140 and 148. And those mutations by themselves confer relatively little resistance to dolutegravir, cabotegravir, or bictegravir. However, if you add sufficient numbers of mutations to the 140 and 148H mutation, you can see a cross-resistance to these newer agents. In addition, other mutations, notably the mutation at position 118 and mutations at 236, and other combinations together with the, 263, and combinations with the 263 mutation confer resistance to dolutegravir and cabotegravir, and to some extent to bictegravir as well. Well, let's look back at the beginning of the use of integrase inhibitors in antiretroviral therapy at what patterns of resistance we saw. The benchmark study was the first phase 3 trial of an integrase inhibitor conducted now more than a decade ago, and it was done in patients who were failing antiretroviral therapy with what were then the standard of care regimens, essentially nucleoside analogs together with with a protease or a non-nucleoside RT inhibitor. Here, what you can see is that patients who had virologic failure on the raltegravir accumulated mutations particularly at position 148, which led to resistance to raltegravir, but there were also other patterns of resistance that emerged, including changes at positions 155 and 143. As more evidence became available, it became clear that the 155 mutation emerges first and is then replaced by the mutation at position 148, which accumulates co-mutations at position 140 and at other positions. The reason for this is that the 155 mutation is a much fitter mutation than the 148, but then when the 148 mutation is accompanied by the 140S mutation, those dual mutations are fitter than the dual mutations that emerge with position 155, as shown in work that we published 10 years ago. Now, the STARTMARK study was a study of raltegravir used as initial therapy. And what you can see at the bottom of the slide here is that in this study, raltegravir was compared to first-line use of efavirenz, and roughly half of the people who had virologic failure with efavirenz developed resistance, the typical K103N mutation, along with other mutations. And about half of the patients who had virologic failure on raltegravir developed resistance to raltegravir. Now, these were a relatively small number of patients out of the entire population. But nevertheless, the rate of Raltegravir resistance was relatively similar to the rate of resistance seen with the NNRTI, suggesting that there wasn't a particularly high barrier to resistance for Raltegravir. The same was true with Elvitegravir. This study shows the comparison of Elvitegravir given as a fixed-dose combination with cobicistat, FTC, and tenofovir in the TDF formulation to the fixed-dose combination of efavirenz, FTC, and TDF. You can see that there were about 15 or so patients in each group who had resistance testing done at the time of virologic failure, making up around 5% of the total study population. And in each case, 2% of the patients who had who received Elvitegravir and 2% of the patients who received efavirenz developed resistance mutations. So again, low numbers overall, but similar proportions, suggesting that the barrier to resistance for Elvitegravir was no greater than the barrier to resistance to an efavirenz-containing regimen. Now, the spring study compared Raltegravir to dolutegravir, and again, we see that there was resistance that emerged in the Raltegravir group, whereas there was no resistance in the dolutegravir group, this second generation integrase inhibitor. Similarly, when dolutegravir was compared to efavirenz, we saw the expected incidence of resistance to either the nucleoside backbone or to the NNRTI in the efavirenz group, but there was no resistance to dolutegravir in the integrase inhibitor arm, nor was there any resistance to the backbone nucleoside regimen. Very similar data were seen with bictegravir, another second-generation integrase inhibitor. Here, bictegravir, as the fixed-dose combination with FTC and the TAF formulation of tenofovir, was compared with dolutegravir plus FTC TAF. And in neither arm was any resistance observed, suggesting that these second-generation integrase inhibitors have a much higher barrier to resistance than observed with the first-generation drugs. The same was seen when BF-TAF was compared to the fixed-dose combination of dolutegravir, abacavir, and 3TC. Note that there were very few patients, only 1 in the bictegravir arm and only 4 in the dolutegravir arm, who met criteria for resistance testing to begin with. Dolutegravir has also been studied in patients who had previous failure on an integrase inhibitor regimen. This was early in the development of dolutegravir when it was studied in patients who had failed on a Raltegravir-containing regimen. And what we see in this slide is the fold change in susceptibility to dolutegravir at entry into the Viking study as a function of the number of Raltegravir resistance mutations. And you see a clear gradient. Patients whose virus carried only a Y143 or N155 mutation had between 2 and 4 to 6-fold change in susceptibility to dolutegravir, whereas the fold change for those having a 148 mutation together with other mutations had 6-fold and greater change in susceptibility. With the greatest change or loss of susceptibility occurring in patients whose virus carried a 148 mutation plus 2 other mutations, as you can see there. In the study overall, the primary endpoint was the percent of patients who achieved a significant reduction in virus load. And you can see that roughly similar proportions did so in the once-a-day versus twice-a-day group, but much more people in the twice-a-day group getting to a reduction meeting the primary endpoint, about 96% versus 78%, with a somewhat greater change from baseline in plasma viremia. It's important to note that although it appears that the twice-daily group had a greater proportion reaching the primary endpoint, fewer of the patients in the twice daily group had very high level resistant virus compared to the once daily group. So although this study is the basis for recommending twice daily dolutegravir in the setting of integrase inhibitor resistance, I think the data are less than airtight. Even though dolutegravir resistance has not been seen in any of the phase 3 randomized trials of treatment-naive patients, resistance can occur. And that was best illustrated in this patient reported by Rafi Landowitz and colleagues from UCLA, somebody with primary infection and very high levels of viremia at the time that treatment was initiated with tenofovir, FTC, and dolutegravir. You can see that there was an initial sharp decline in viremia, but then the decay in virus load seems to have stalled, and there was a slight rebound that was accompanied by presence of resistance mutations. And then the regimen was intensified, and there was further reduction. But deep sequencing at time point C showed emergence of several integrase inhibitor resistance mutations, including changes at positions 148, 151, and 163. The sailing study compared dolutegravir to raltegravir in treatment-experienced patients. And you can see that overall, although the difference is small, there was a greater proportion of participants who achieved a virologic suppression in the dolutegravir arm compared to the raltegravir arm. Now, these were not integrase inhibitor experienced participants. They had failed on other regimens, and this difference was statistically significant. Resistance mutations did appear, however, in 4 of the participants in the dolutegravir arm. 2 of them had mutations at 148 and 140, as well as at 263. And resistance emerged much more commonly in the raltegravir arm, and this was a statistically significant difference in proportions. Well, what about resistance to dolutegravir in other settings? Because of the success of dolutegravir in the triple drug regimens and in 2-drug regimens, which I won't be speaking about, but which Pedro Kahn will talk about subsequently, there was unwarranted enthusiasm about examining the potential for dolutegravir to be used as monotherapy. This slide shows a range of studies, and in all but one of the studies, which the study from Italy that had only 20 participants, not only was virologic failure observed, but in all of the in many of the participants who had virologic failure, there were resistance mutations to dolutegravir that emerged, as you can see in the right-hand column. Well, what about cabotegravir? Cabotegravir is structurally similar to dolutegravir, but not identical. And cabotegravir has somewhat different resistance patterns compared to dolutegravir. There are 3 studies that have been conducted, Atlas, Atlas 2M, and FLAIR, of cabotegravir administered as a long-acting injectable in combination with long-acting injectable rilpivirine as a 2-drug regimen in place of daily oral therapy. The Atlas and FLAIR studies demonstrated the non-inferiority of monthly injectable cabotegravir plus rilpivirine compared to continued daily oral therapy, but did note the emergence of resistance to cabotegravir initially in 6 participants, as shown in this slide, 3 from Atlas and 3 from FLAIR. Now, what you'll notice is that 5 of these 6 participants came from Russia, and although the viruses here are designated as A1 subtype, in fact, they are subtype A6, the subtype that circulates in the Russian Federation. This subtype is notable for the fact that it has a polymorphism at position 74. And you see that all of the Russian isolates have this 74I mutation. 74I by itself does not confer resistance to cabotegravir or to dolutegravir, but in 4 of the 6 participants, additional integrase inhibitor resistance mutations were found at the time of virologic failure. And you can see those in the table here. Some of these participants, in retrospect, turned out to have baseline resistance mutations for rilpivirine, and that may have contributed to the occurrence of virologic failure and predisposed then to the development of integrase inhibitor resistance. The Atlas 2M study was a follow-on study for Atlas, where participants were then followed for an additional 48 weeks and randomized to either continue on once monthly injections or every other month injection. And again, the 2 regimens were shown to be non-inferior. But that allowed for a larger analysis of all of the resistance data, which was presented at the Glasgow meeting a few months ago, and the results of that analysis are shown here. Factors that were associated with virologic failure across these 3 studies included the presence of rilpivirine resistance-associated mutations at baseline. That was based on a retrospective analysis of proviral DNA. The week 8 rilpivirine trough concentrations, essentially a pharmacokinetic measure of rilpivirine exposure. So the lower exposure to rilpivirine, the greater the risk of having virologic failure. Having a virus that belonged to subtype A6 was a significant risk factor for virologic failure, as was having a high BMI. So for every additional kilogram per meter square of BMI, there was about another 13% increased risk of failure. So there was no single factor that was important, but all of these factors together were highly significant. So in conclusion, resistance to dolutegravir and bictegravir has not been observed in trials of treatment-naive participants when triple drug regimens have been used. Dolutegravir resistance can emerge in treatment-experienced patients and in dual or monotherapy. I should state that dolutegravir resistance was not seen in the Gemini or Tango studies of dolutegravir 3TC dual therapy, but was observed in a pilot study conducted by the ACTG in 2 or 3 participants who had demonstrated non-adherence. Shared mutations across the class of integrase inhibitors can result in cross-resistance if enough mutations accumulate. And as with any drug, dolutegravir monotherapy should be avoided. Although the barrier to resistance for dolutegravir and bictegravir is high, these drugs are not foolproof, as illustrated by the emergence of resistance to monotherapy. Intermittent adherence and inadequate drug exposure increase the risk of integrase strand transfer inhibitor resistance, as they do for all antiretroviral agents. And lastly, resistance to cabotegravir has been observed in trials of cabotegravir long-acting in combination with rilpivirine long-acting, and the implications of this resistance for response to other integrase inhibitors in subsequent regimens still requires further study. With that, I will conclude my presentation and turn this back to the moderator.